This is Justine Spargrove recording Learning Plan 8, Processes and Stages of Labor and Birth, with Chapter 16 and 17. All right, so our objectives today are to differentiate between false and true labor, describe the physiologic and psychologic changes that occur in an expectant woman during each stage of labor in the nursing care management of the expectant woman, explain the maternal and systemic responses to labor in the nursing care of the expectant woman, and then evaluate the progress of labor by assessing the laboring woman's contractions, cervical dilation, and effacement. All right, so let's talk about the critical factors in labor. So there's the 5 of them. We can call them the 5 Ps. So the first one is passageway, which is the passage through the birthing canal, basically the structure of the pelvis, of a woman's pelvis. And then the soft tissues is what that makes up. Then we have the passenger, which is considered the fetus, and the placenta are the passenger in the uterus. Then we have positions of mother, which is the relationship between the fetus and the passageway. Then we have power or physiologic force of labor, so like the strength of the uterine contractions and pushing. And then we have psychological response of mom. So any one of these forces can actually alter the outcome of a labor and jeopardize both mom and her babe at any point in time. So we're going to go through each one of these factors. All right, so the critical factor 1 was the passageway of the pelvis. So if you look at this picture here, this is actually a pelvis. If you're looking directly face on, facing a woman, this is what you would see in her pelvis. So we have the pelvic inlet, which is inside the pelvis. Then we have the mid-pelvis, which is right here, which is that midline area. You have little bones kind of sticking out. And I'll show you some of these in class on a pelvis. And then we have the pelvic outlet. So when we talk about different stages of labor, we're going to talk about where is that baby's head and in proportion to this pelvis. So I want you to remember this pelvis here because that'll make a little bit more sense as we start talking about some different things as babe goes through the what we call quote unquote the birthing canal. So again, we have the pelvic inlet, which is when they first get into the pelvis area. Then we have the mid pelvis, which is the halfway through. And then we have the pelvic outlet, which is that last bony prominence coming through the pelvis. All right, so for the passageway, Caldwell and Malloy classification of pelvises is kind of what we're looking at. So there's four different, I guess, types of pelvises. There's the gynecoid, android, anthropoid, and platypoid are the different kinds of pelvises that a woman may have. So these are, in its perfect essence, the exact shape of what they are. So the first one that we see here, working down this way, is the gynecoid. So the gynecoid is the most common and the most favorable for vaginal birth. So if we look at this pelvis, you can see that it's really like almost uh it's it's a heart shape. They're all heart shaped, but this one's kind of the biggest across and then biggest lengthwise and width. Okay, so it's got the biggest area overall compared to the other ones if you're going to compare them looking at it this way. You can see it's pretty big here if we look at the top compared to some of these other ones. Here again, it shows you the length and then it shows you the pelvis point. So we're really looking at the baby's really got to be able to fit through this mid pelvis area, which is that bony prominence there that it keeps showing here. Okay. And then the pelvic outlet's got to be sufficient. So all of these things have to be favorable. So that pelvic inlet, the mid pelvis, and the pelvic outlet all have to be adequate size for baby to fit through there. Otherwise, baby's not going to fit and we have to do a C-section. So that's really why we're looking at this. Now, the next one that we have is android, which is this row here. So the android is not favorable for vaginal birth because it's heart-shaped with short or reduced diameters throughout. It leads to a slow descend into the pelvis. And then the fetal head enters the pelvis in a transverse or posterior position. So it really isn't ideal for that head to fit through there because we'll learn the different um, movements of the baby and the baby's head as it moves down through that birthing canal. And this is not favorable at all because the baby's head's going to turn sideways when it comes through here. And it's not going to fit that way. Okay. Next, we have the anthropoid, which is right here, the third row. So this is favorable for vaginal birth because the inlet, that pelvic inlet, is oval in shape with long anterior posterior diameter. And then the mid pelvis, that midway point, and the outlet diameters are adequate. So this one is more favorable because if you look at right here, gives a good picture of, okay, baby's head may be able to fit through there. We don't have all these obstructions, like we have some bony prominences here from the pelvic outlet and the mid pelvis and things. Here it can fit. So it's not the most ideal, but baby can fit through the anthropoid position or the anthropoid pelvis. And then the very last one that we have is the platypoid, which is that last one. Now that one's not favorable for vaginal birth because the inlet is oval in shape with long transverse diameters, and then the mid pelvis diameter is reduced and the outlet is inadequate. So you can get halfway through, but if you can't get through that pelvic outlet, um, it's a no-go. You have to be able to fit all the way through, not just through half of the pelvis. The fetal head usually engages in a transverse position, and so then it's difficult to descend through that mid pelvis. And most of the time, you have a delay of progression in the outlet of the pelvis. So it gets part of the way through, and then it just kind of gets stuck in there, so to speak. So again, our gynecoid is the best that we like, and then the next would be the anthropoid. The android and the platypoid we don't really like much because it's a no-go to have baby try and go through the passageway that way. All right, so now let's talk about critical factor number 2, which is the passenger, the fetal head, more specifically. So the fetal skull or cranium consists of the face, the base of the skull, the vault or roof of the skull. So those are the 3 main components. Now the vault has 2 frontal bones, 2 parietal bones, and then the occipital bones. So again, we have our 2 frontal bones here. We have our 2 parietal bones, and then we have an occipital bone back here. So there's 5 bones total that we're looking at. And now those bones are not fused, so the head can adjust in shape and overlap. It'll actually completely overlap as it passes through the pelvis. And when the bones overlap, we call that molding. So that's where you get the baby who's got kind of the cone head that's really oblong in shape. It's because these bones can actually overlap on one another to help baby come through that birthing canal or the pelvis. Some babies look like they have cone heads after being delivered, but again, don't worry about that shape of the head. It'll return back to normal. It's a short amount of time. Sometimes there could be bruising too, but again, the shape will not be permanent. You won't have an oblong or cone head child forever. Now, the sutures of the head are membranous spaces that are between the cranial bones. So the important sutures of the cranium are that frontal bone, the sagittal, coronal, and lambdoidal sutures. The intersections of the cranial suture are called fontanelles. The fontanelles help identify the position of the fetal head during the vaginal examination. So when we actually do a vaginal examination on a woman, we put our hand in the vagina, and we're actually feeling for these sutures here. We want to feel which way is baby facing, because that'll help us know if we're going to have a hard labor, are we going to have back pain, are we typically looking at maybe a C-section because of the way baby's trying to come down through that pelvis. So we feel for all these different sutures or these fontanelles to figure out which position baby is in. Now, the anterior fontanelle is a diamond shape and allows growth of the brain and is unossified for up to about 18 months of age. And then the posterior fontanelle is smaller, kind of like a small triangle, and closes at about 8 to 12 weeks after birth. So again, when we're feeling, doing a vaginal exam, and we're feeling for a baby's head, we feel for those fontanelles So we would feel for the anterior fontanelle, and then we may feel for that posterior fontanelle, so then we know which way baby is facing. All right, so fetal skull measurements, I don't expect you to remember how long or how wide these are. It's just so that way you can kind of see if baby's in different positions, what the distance is as far as maybe why they're not being able to come down through that birthing canal because of the way that their head is positioned. One way is going to be more narrow than another position. So they vary considerably, but also within normal limits. There are ranges. Some areas are shortened while others are lengthened during labor. And while the head is molded, then those will also change in size. The fetal head diameters are measured between different landmarks. So as you can see here, we have a landmark here that we use, and we have measurement here that we use. Like if baby's face was presenting, meaning that baby's face, if you're feeling the vagina and you feel baby's face, you're going to have probably a rough measurement of about 9.5 centimeters. And we know mom dilates to at least 10. That's if babe is average size. However, if baby is presenting, meaning that baby's coming down to the birthing canal, we feel in the vagina to feel where baby's at, and we feel a chin, or maybe the top of the head, right up here at the very top of the head is what we're feeling. Um, we may potentially have a long measurement of 13.5 centimeters. Well, do we know that that body will stretch that far? Mom dilates 10 centimeters. So we may have quite a bit of molding going on to help baby kind of squeeze through there. Okay, so there are fetal skull measurements, but again, I don't expect you to remember those measurements at all. Okay, so here's a great picture of the diameters of the head in relation to the pelvis and how the fetus may actually present. So here we have what's called a vertex presentation, where the very top of the head is what is coming down through that pelvis. So that's what we call the presenting part. So it's the first part that's presenting itself as it's coming out to the world to be introduced. Okay, so again, vertex presentation. Here's a rough measurement on average with the perfect pelvis, what it would be. So it'd be 9.5 and 9.25. Now, if we have a syncopate presentation, so you can see that it's not at the very top of the head, it's kind of tipped forward. Then that would be a little bit longer measurement. So now we've gotten 12 centimeters versus our 9.5 centimeters trying to fit through that pelvis. And then, then we have the brow presentation. So that's kind of like the face is coming first. And so again, our measurement gets even bigger, 13.5 centimeters and 9.25 centimeters. So that's got to try and fit through that pelvis. So if baby's not coming and presenting the right way, it can make a really hard labor for mom. It can make long labor for mom, or it could end up in a C-section. So it's very important that we know how is baby coming out so we know what to anticipate as far as our next actions as a nurse. All right, so fetal attitude, and no, I don't mean that they're sassing back at you. That's not what I mean. So fetal attitude is the relation of the fetal body part in relation to each other. So like a general flexion. So babies usually squeeze up and kind of curl up in a ball as they're in the uterus, and then they start descending and coming down into the pelvis. So the head is typically moderately flexed at midline. So it's usually pretty moderately flexed in towards like the chin to the chest. The extremities are usually flexed pretty close to the body, arms over the chest, knees flexed on the abdomen like we were to try and curl up in a ball. And then the fetal head flexion, the more the extended the head, the wider the head is and may not be able to enter into the pelvis. So that's basically what the last slide that I just showed you, where if the head's pretty extended instead of flexed, then we get that wider diameter and it's harder to come through that birthing canal. So here are some pretty common um, fetal attitudes. So again, we already kind of looked at the vertex presentation where baby is completely flexed and squeezed and the top of the head is coming down. So that's an ideal position that we'd like to see. Then we have what's called a military presentation where the baby is moderately flexed, but as you can see, it's not quite as squished up in there as we'd like to see. The knees and the arms and everything aren't quite flexed. So again, that diameter lengthens. Then we have that brow presentation that we talked about. That's got that pore flexion, so it's kind of like the eyebrows are what's presenting first, and that's kind of what we see coming through or feel coming through the pelvis. And then we have the face presentation. So the face is completely coming through, right? We go to check bomb, and that's what we feel are the complete facial features. And again, that has full extension instead of flexion, and then we end up with a even wider diameter trying to fit through that pelvis. All right, so let's talk about fetal lie. So fetal lie is how the baby is positioned in the birth canal. So it's the relationship of the cephalocaudal axis of the fetus to the maternal spine. So what that means is where's baby's spine in relation to mom's spine, or the back of the head, the occiput. Okay. So the fetal lie is either longitudinal, head or butt in the pelvis. So this would be longitudinal head, or butt, that'd be longitudinal, or transverse, which would be, we could say shoulder, but it doesn't necessarily have to mean that the shoulder is actually the presenting part down here that we may feel. It could be the back, it could be part of the hip, it could be part of the knee showing, okay? That could be transverse. So it's just saying that baby is laying sideways in mom, essentially. And we call that usually breech. We also call this, with the butt presenting, also a breech presentation as well, meaning that baby is not coming out that way, it's stuck. Okay, so we talked about cephalic, breech, or shoulder. Those are the kind of the three names that they're given. So shoulder or transverse lie is like the shoulder, the arm, back, abdomen, or side could be presenting, could be what's coming, trying to come down through that pelvis as a presenting part. Cephalic is further classified as head first, but what part of the head? So it could be the vertex, the occiput, brow, or face. Like we said, that head could be either flexed or it could be extended. So that's good to know. And then the vertex presentation, which occurs in about 97% of term births, where the head is completely flexed into the chest and the occiput is presenting part. So that's, again, the ideal is the vertex on that. All right, cephalic presentation variations. So we kind of already talked about these different ones where we have the vertex presentation. We have complete flexion of the head, allows us the suboccipitobregmatic diameter to present in the pelvis. Down we have the syncoput, median, could be vertex, military style presentation with no flexion or extension. And the occipital frontal diameter presents the pelvis. We have the brow presentation again, where the fetal head is completely extended, and then the subbregmomatic diameter presents the pelvis, or we could have that face presentation where the fetal head is in partial extension and the occipital mental diameter, which is the largest diameter of the fetal head, presents into the pelvis. So again, that first one, the vertex presentation is ideal, but we can deliver in most of these. Face, you could still deliver, it's just a little bit more difficult. All right, variations in breech. So again, we've already kind of touched on this briefly, but in breech, either the buttocks and or feet are the presenting part, and occurs in about 3 to 4% of births, term births at least. The sacrum is the landmark to be noted upon examination. So you're going to feel for the sacrum of the babe. Complete breech is the buttocks and feet are actually presenting. Frank breech is just the butt. So if you want to give a name to the butt, you can call it frank. And then the footling is just foot or feet hanging out through the pelvis. All right, so critical factor 3 is position, so relationship between the fetus and the passage. So we talk about engagement, station, and fetal position on this one. So in this nice little picture, we have +4 station and delivery. So the nurse says, or the doc says, nurse, why didn't you tell me she was so close to delivery? And they said, I told you 15 minutes ago she was at a +3. So +4 is on the floor. Okay, so stay with me here. We're going to move to the next slide, which will make so much more sense for this. So here is the relationship between the fetus and the passage, the engagement, and the station. This is where I told you to remember that pelvis, that where those bones are at. We use those bones to help us determine how long is it going to be before baby comes out. Where's baby at in that pelvis? Is it almost completely out of the pelvis, or is it just coming into the pelvis? Okay. So engagement is the largest part of the presenting part, reaching or passing through the pelvic inlet, and is at the level of the ischial spine. So the ischial spines, oops, all right, here. This can be determined through a vaginal exam. Prima gravida, or first-time mom, occurs 2 weeks before term, usually. And then multipara could be several weeks before or during labor. And then the engagement confirms the adequacy of the pelvic inlet, but not the outlet or mid-pelvis. So the engagement is when babe actually gets up here and is starting to come down and actually, if you want to think of it as like touching, the head's touching the pelvis from the inside, that's what we call engagement, that baby is now engaged. Okay. So again, it confirms adequacy of the pelvic inlet, but not the outlet or mid pelvis. Because again, it's only hanging out up here. We don't know if it's going to fit through here or here at that point. We only know that, yep, it could sit here. It's fitting here. Okay. Now, station is the relationship of the presenting part to an imaginary line between the ischial spines. The ischial spine is the narrowest diameter for the fetus to pass. So if the presenting part is higher than that ischial spine, it's given a negative number because it's farther away, it's in the negatives. If it's at that line, it's a 0. And when it's past that line, it's given a positive number. Okay. So here is a -4 because it's farther away. Baby can be what's considered floating up here yet because it's not it's not completely engaged with your ischial spines here, which is that narrowest part. And so if I were to check mom, do a vaginal exam, I could put my hand up there and I may be able to push on baby's head a little bit, and it may actually float away and then come back down. We call that sometimes blottable, that baby's blottable, that it'll float away and come back to us. Then once it's actually at those ischial spines and touching, if you want to think of it that way, trying to fit through that narrowest part, it's considered engaged, and it's at a 0 station. So it's like it's halfway through the pelvis. And then once we start past that, we start getting positive numbers. And then we get +4 is at the outlet. So baby's crowning by that point. So that's why the other one, it says +4 is on the floor. That's how you remember that +4 is the pelvic outlet, not the pelvic inlet, because +4 is on the floor. They're almost out. Okay. We have another little picture over here that's got the fetal station, relationship of fetal head to mother's pelvis. It says, I'm at 0. From here, it's all positive. I'm on my way out. So again, little things to help you remember things. Okay, so fetal position. Fetal position is the relationship of the designated landmark on the fetal part to the front, sides, or back of the mom's pelvis. So the landmark for vertex, which is the ideal position, the landmark for vertex is the occiput, so the baby's back of the head, the occipital bone, and the landmark for the face is the mentum. So if you think about that chin, that the mental, um, I'm trying to think of what it was that we called it. I always think mental, like I'm thinking, I go, and put my finger on my chin. That's mental because I'm thinking. And then breech is usually the sacrum or the acromion process of the scapula. Now, R is for right, L is for left side of the maternal pelvis. So this is on mom. So this is in mom's right side and mom's left side, not baby's right side, baby's left side. This is mom's pelvis, the right side and the left side. So if I'm looking at mom, it's going to be flipped. So right would be my left, left would be my right. Okay. Now, O stands for occiput on baby. M is for mentum. So again, that's the chin. I go, and S is for sacrum. So that's the buttocks. And then A is for acromion process, or like that shoulder presenting part. And then we use A for anterior. So which position is it in relation to mom? Is it P posterior, or is it T for transverse in mom? Okay. So the most common fetal position is occiput. So the back of the head is anterior on mom. So the back of the head is in the front of mom's abdomen and is likely to proceed a normal with labor and birth. And then other positions are more frequently associated with problems during labor and are termed male positions. So the occiput anterior is the most favorable. So like this position here would be the most favorable because baby's occiput is anterior. Okay, so that's what I'm talking about. So if I have LOP, so that is left, baby's on the left side of mom, because remember, if I'm looking directly straight onto mom, mom's facing me, I'm talking to her, and this is what you're seeing, then baby's occiput, the back of the head, is the presenting part. See, it's baby's all flexed, so that's what's presenting is the back of the head. And it's on mom's left side of her body. And the baby's back of the head is on the posterior side. So it's back here on the back side, kind of facing the spine. Now then I have left side where the occiput again is presenting, but it's transverse, so it's side to side. Okay, so it's directly kind of midline on the side. Then I have left side again. The occiput is the presenting part, but now it's anterior, so the baby's kind of shifted. So see here in this picture, you can see the baby's kind of eyebrows and eyes here. Now I get the back of the head. There's the ear, and here's the back of the head. So it's anterior because the occiput is facing mom's front, the anterior. And then down here are just basically the opposite. So now babe's occiput is presenting, but it's on mom's right side and it's facing the back. Then we have it transverse, and then we have it towards the front. Okay, so again, that's what they look at. And this is how I would be feeling. Here, this picture here, if I had my hand in mom's vagina and I was feeling for which position baby's in, I'd be feeling for those fontanelles to see, okay, is this a posterior fontanelle? Is this an anterior fontanelle? Which one is it? So then I can determine which position is baby in, and then that'll help me know, am I going to have potentially long hard labor? Am I looking at C-section, or is baby in the most favorable position that that we're not going to have any problems? And a good thing to know this for also is C-section, especially C-section. So if it's second shift, day shifts just finishing up and surgery's getting ready to go home, the surgery may call down or call over and say, hey, you know, do you have any moms and babes? Because I'm on call and I'm wanting to know, should I be on call? And you go, oh, baby is anterior or posterior. And yep, you're looking at, a potential for a C-section. Or nope, baby's in the perfect position. I wouldn't be too worried. That's not to say it wouldn't happen. But then you kind of have a little inkling of what's going on. It's always good to be more prepared and to have as much information as possible when you have a mom in labor, because you never know what's going to happen between babe, the labor process. You never know. It's always good to be more prepared than not prepared enough. And then we have another picture up here in the corner of here that says, that's my occiput, that's your posterior. So OP, occiput posterior, is what position we would say that. That's like this one's OP. Okay. And I will show, we'll go through this again in class as well, to try and show you some different positions. All right, fetal male positions. So these are bad positions that we don't like to see. They're associated with problems during labor. So again, just to reiterate, M is that mentum, so like that chin's the presenting part. Then S is that sacrum or the butt, and then A is acromion process. Okay, so these are just examples. We will go through some more examples in class as well. All right, critical factor number 4, which is powers. So There's two forces of labor, which is the primary powers and then the secondary powers. Primary powers signal the beginning of labor, which is like uterine contractions, which are involuntary contractions responsible for the effacement and dilation, so the thinning and then the dilation of the cervix. And then the secondary powers would be the pushing with abdominal muscles. So that's mom actually pushing herself. So the first one is the uterus contracting, doing work for mom, and she's not doing a whole lot. And then the second one is mom actually doing the work of pushing with her abdominal muscles. The secondary power causes the expulsion of the fetus and aids in the primary force after dilation. So they kind of work together. And then it's always good to know that you don't want to have mom push until she's dilated to 10 centimeters because that may actually cause cervical edema. So all that swelling can cause trauma and may actually delay birth or may not allow birth to happen because we want mom to dilate to 10 centimeters. And now if we have swelling, that 10 centimeters may have gone down to 6 centimeters that we're trying to get baby out. Even though she's fully dilated, we have swelling in there. So never allow mom to push until she's to 10 centimeters. All right, force of labor contractions. So there are some different phases of contraction, and we'll go through more in detail in class on contractions. We'll do some practice things together, but we are going to talk about them here. So we have phases of contractions. So we have increment, which is the building up of a contraction, which is the longest phase. Then we have, excuse me, right here, which is kind of like going up to that peak. Once we hit the peak, we call that an acme, which is that peak of that contraction. And then we have a decrement, which is release of a contraction. So that's the whole contraction in itself. So we have the increment, we have the acme, and the decrement, which is the downside of the contraction. Now we also have frequency, which is the time between the beginning of a contraction to the beginning of the next contraction. So when we look at this slide here, we have the frequency, which is, again, beginning of one contraction. So from where it leaves the baseline until it leaves the baseline again. Okay, so it's when it leaves the baseline to where it leaves the baseline again. That's a whole frequency. So it happens that long. Okay. Next, we have the duration, which is the length of a contraction, which is the measurement from the beginning of a contraction to the end of that same contraction. So that's a little bit different. So before we went to the beginning of the contraction to the beginning of the next one, now our duration is just that contraction alone. So when did it start? When did it stop? So that's considered the duration of the contraction. And then we have the intensity, which is the strength of the contraction during the acme or that peak point. And that's usually estimated by palpation. So we usually go by mild, moderate, or strong. A lot of times to try and gauge how hard the contractions are, yes, we have a TOCO on the stomach that kind of tells us what how strong those contractions are, but that's not perfect, especially if it's on the outside of the body. It can have a lot of variables that play into that. So besides just looking at the numbers, you may see a nurse do this. Mild would be like if you put your finger on your nose and kind of squish your nose in, push it in. That's considered mild. That's what a mild contraction would feel like. It's kind of squishy. And then a moderate would be more like a chin. So put your finger on your chin and kind of push on your chin. It's a little bit more hard than the nose. So that'd be a moderate contraction. That's what that would feel like. And then a strong one would be like a forehead. Put your finger on your forehead. It's definitely a lot more strong. So that's what a strong contraction would feel like. It'd be really tight and it'd be hard. So you may see a nurse kind of turn around and maybe touch her face a little bit. That's what she's doing. Now there's also numbers that we may use during intrauterine catheter that to measure the pressure. So we may actually put a catheter up in there that measures pressure. If we're looking at specific numbers intrauterинely, these would be our numbers. It would be like 25 to 40 millimeters for HD would be early labor. If we're going to look at those numbers again, 50 to 70 for pressure would be active labor. 70 to 90 would be transition, and then 70 to 100 would be pushing. So if you're looking at specific numbers, that's what we'd be looking at. All right, labor onset. So 38 to 42 weeks of gestation is your typical time that's considered full term that we usually have moms or would ideally like to have moms deliver. We have progesterone, which relaxes smooth muscle tissue, so the body actually releases that progesterone. Then we have the estrogen, which stimulates uterine muscles, so that way the body can start contracting. And then we have the connective tissues that actually loosen. So that loosening actually permits the softening, thinning, and then eventual opening of the cervix because the cervix is pretty thick. So that way we can't let anything in to give baby bacterial infections or anything like that. So it's pretty thick. And eventually, as you get closer to delivery, your body starts releasing the progesterone and estrogen. And then the connective tissue start loosening. So that way that cervix can start softening and then it starts thinning out, getting thinner, getting ready to open up, and then dilate to let baby out. All right, let's talk about signs of labor. So there's lightening, which basically the fetus settles into the pelvis, and then the fundus is no longer presses on the diaphragm and allows for easier breathing. So usually moms can't breathe, and then all of a sudden they're like, "Oh my gosh, I can breathe all of a sudden." Well, baby's now settling or you having lightening, and baby settling down into that pelvis. However, the downside of that is now that there's an increased downward pressure that causes your legs to cramp from pressure on the nerves. You're gonna have increased pelvic pressure, so you're like, oh my god, baby is like right there. I feel like it's gonna fall out. You can have increased venous stasis, leading to more edema. So that's why you get all that edema in your legs, or mom gets all the edema in her legs towards the end of pregnancy, is because now baby's shifted down, and so that blood supply can't get back out. And then you could have increased vaginal secretions because again, you got something hanging down there, and you also have the body starting to thin the cervix and everything else. So you're going to have a little bit more discharge. Then we have Braxton Hicks contractions, which are irregular intermittent contractions. So there's no rhyme, reason. They just are what they are. They can become uncomfortable, and mainly in the abdomen or groin is where mom may feel them. They can be strong enough to lead to false labor, though, and then they can be regular, and then the woman can go into true labor without knowing it because she's like, oh, it's just Braxton Hicks and stuff. And it's not until later throughout the day that they've gotten a lot stronger, and all of a sudden, oh, I'm really noticing these. Oh, maybe I should time these. Oh, they're pretty close together. Oh, maybe I'm in labor now. Now, the only true way of knowing if mom is in true labor is if you actually do a vaginal check and see if there's dilation. So true labor is when there's actual dilation occurring of the cervix. So it's the only true way to know the difference between it. You can definitely speculate, but really, by definition, it would be the actual dilation and changes of the cervix happening because of those contractions. And then finally, we have the cervical softening and the effacement. So the beginning of pregnancy, again, the cervix is firm, it's kind of rigid, and it needs to soften and stretch or ripen and then dilate to allow the passage of the fetus. Sometimes doctors may actually help mom out if they're not ripening or stretching and thinning on their own, and they may actually put their finger in there and kind of do one quick swirl around with their finger to try and, I guess, break the seal of it against the cervix, which is very uncomfortable for mom, but it helps so that way the body can kind of naturally start getting going. Signs of labor could be bloody show, which is the softening and the effacement, and the expulsion of the mucus plug, which is that plug that's up in the cervix that again is real thick that doesn't allow any bacteria or anything to get into the uterus to contaminate babe, make babe sick. And it's usually pink tinged secretion. It can be actually bloody. It can come out a little at a time. It can come out a lot at a time. It's kind of like sometimes it's kind of like jello, like thick red jello or orange type jello. It can be stringy. It can be kind of chunky. It can be all different colors and shapes and things. And that is considered a sign that labor will begin within 24 to 48 hours, but not always definite. So that doesn't mean that, oh, I have bloody show that now I'm going to go into labor. Well, that may not be the case, especially if baby is up higher in the uterus and is not even pushing on the cervix to help the cervix to dilate with its head. Just because you lost your mucus plug doesn't mean things are going to happen if baby may be too big for your pelvis or the pelvis isn't the right size or shape for baby to come down and help dilate and get things going. Another sign could be a sudden burst of energy 24 to 48 hours before labor starts. We aren't really sure what causes that, but make sure that you tell mom not to overdo it and eat small, frequent, nutritious meals and rest, because we don't want mom to overdo it and then now she's in labor and she's cleaned the whole house and so she's just exhausted and has no energy to push or really help with getting babe out. Another thing may be a weight loss of 1 to 3 pounds from the fluid loss and electrolyte shifting, getting ready for the delivery. Mom may have diarrhea, indigestion, nausea, or vomiting prior to labor. Sometimes she has a rupture of membranes. However, only 10% of women actually rupture their own membrane. So that's a really little amount, even though movies always show everyone's water breaks. That's not really ideal. But 90% of women after spontaneous rupture of membrane, that's what we call it when it ruptures on its own, that doc doesn't help at all. We call it SROM, spontaneous rupture of membrane. They'll go into labor within 24 hours. And some will even say delivery within 24 to 48 hours. Labor can be induced within 12 to 24 hours if it does not occur spontaneously to prevent infection to mother and fetus. So if doc went up and went ahead and um, broke mom's bag of waters or basically their bag of waters, their membrane, if they broke it, then we want to make sure things are going within 12 to 24 hours, because the longer that babe doesn't have that sac enclosed around it to keep it safe and keep the bacteria out, the more it's an increased risk for getting a bacterial infection. And then the other thing is if there's not any engagement, so if the baby's head is not down into the pelvis and actually engaged, so I can push it, if I do a vaginal exam and I put my hand up and I feel baby's head and I push on it and it's floating away, okay, if it's at like -4 station instead of a 0, they're actually in danger of an umbilical cord prolapse, which would be mom's water breaks and baby's head's not down in the pelvis in the midline. And now, while it's plottable, it's floating up there. The umbilical cord comes down and gets stuck between babe's head and mom's pelvis, and then we cut off blood supply. So that would be a prolapse cord where that could happen, or the cord can actually hang out through the vagina and babe hasn't even been born yet, and then babe's head is putting pressure on the umbilical cord. So if that happens, you put your hand up in mom's vagina, you push baby's head up out of the way, and away you go to C-section. So that way babe gets the oxygen and blood supply that it needs. Otherwise, it'll clamp off its own umbilical cord and, in an essence, kind of kill itself because it doesn't have the blood supply and the oxygen that it needs. All right, how do we differentiate between true labor and false labor? So true labor contractions occur rhythmically. They increase in frequency, duration, and intensity over time. Usually contractions begin in the back, on the mom's back, and kind of migrate towards the forward towards the abdomen. So it's like someone comes behind you and kind of gives you a hug. So they start their hands right on your spine and slide their hands around the front of your abdomen and then squeeze. If someone's giving you a tight hug, and then they let go and they go in reverse order. So then they slide back around the mom's back, is what a contraction feels like. Now, true contractions are discomfort. They are very uncomfortable. But it's the contraction discomfort's not affected at all by rest or walking. So it continues. Sitting doesn't slow it. It doesn't stop it. It doesn't make it feel better. It just continues. It doesn't change at all. Now, false labor contractions don't cause cervical effacement and dilation. Like I said, true labor is when there's changes. The contractions are usually irregular with no increase in intensity, and the discomfort may be relieved by changes in activity. So if mom's walking around and you think maybe she's got Braxton Hicks, have her sit down and rest a little bit, sometimes drinking a little bit of water, maybe she's dehydrated, and so her uterus is a little bit irritable because it just needs to be more hydrated, will help. And if it goes away, it's definitely Braxton Hicks. But true labor, the contractions will not go away with any type of rest or drinking fluids. All right, let's talk about effacement and dilation. So, we'll talk about this and I'll show you a mannequin in class. But effacement and dilation, we've already talked about where mom can dilate to 10 centimeters before we want her to push. Effacement is like that thinning of the thinning and moving off to the side of the cervix. Okay, so to kind of put it in perspective for you, 1 centimeter dilation would be kind of like a Cheerio or the very tip of your finger. 3 centimeters would be like a typical slice of banana lengthwise. 4 would be a Ritz cracker. 7 would be a soda can, and 8 would be a typical bagel size. So that's how big mom's cervix needs to dilate before we want her to push and babe to come out. Now on here, on this one, we see the cervix not effaced. The length of the cervical canal is 4 centimeters. So see how thick it is here? We want that to kind of thin out. Now, as baby starts pushing down on this, it helps to thin it because you have pressure from the baby. Now the cervix is partially effaced. The length of the cervix is about 2 centimeters here now because baby's weight is pushing on it, helping it to dilate and thin and open. Then we have a cervix is fully effaced, so it's completely thinned. Then we have the dilation that actually starts going on here. So we have dilated to 3, and then we have dilated to 8. So you can kind of see how real thick it gets to how thin it is. So we want it to be fully effaced, so completely thinned, and then to start dilating. Again, here's another good picture. This one's actually from your book that shows the first picture is the beginning of labor where there's no cervical effacement or dilation, and the fetal head is cushioned by the amniotic fluid under it. The next one is the beginning of cervical effacement. So you can see where it really starts thinning there. And the cervix begins to efface. More amniotic fluid collects below the fetal head because now there's more space there down here. Then next, the cervix is about 1/2 effaced and slightly dilated. And the increasing amount of amniotic fluid exerts hydrostatic pressure. So now we got even more pressure pushing down on the cervix to help it dilate and thin because we got baby's head down here and we have that fluid. Now in the prolapse cord, this is where there's happens to be space in here and that cord can slide in through here and kind of float down here and then baby's head will push on it. And then on that last picture here, we have complete effacement and dilation. So then sometimes you may say, I feel a bag of waters if we're checking mom. They may feel that bulging bag of waters, or they may say she's bulging. That's that bag of waters here that they can feel this bulge here, and it will probably pop at any time or with any little poke at all. It'll rupture on its own. And sometimes mom's membranes don't actually rupture until she's actually pushing and then they rupture. All right, let's talk about some stages of labor. So there are 4 stages of labor. The first stage is the stage of cervical dilation. So it begins with the onset of regular contraction and ends with the complete dilation. Okay, so in this stage, we have the latent phase, which is the dilation from 0 to 4 centimeters. The active phase, which is dilation from 4 to 8 centimeters, and then the transitional phase, latent phase should be 0 to 3 centimeters. Active phase is 4 to 8 centimeters, and then transitional phase is 8 to 10 centimeters. So you may hear a nurse talk about what phase she's in. They're just talking about where are they at as far as the dilation scale. That's the first stage. Now, the second stage is the stage of expulsion, which begins with the complete cervical dilation and then ends with the delivery of the fetus. So by the time they're dilated to 10 and then they deliver the baby, that is the second stage of labor. Now, the third stage is the placental stage, which begins immediately after the baby's born and ends with the placenta being delivered. And then you may or may not hear about a fourth stage, which is the maternal homeostatic stabilization stage. So that's basically after the delivery of the placenta and continues for like 4 hours after delivery, just making sure that mom stabilizes and body kind of naturalizes back on its own. All right, so there are cardinal movements of labor. So this is the positions that baby is in to get out of the birthing canal, essentially. Baby's got to flex to move in certain ways in order to squeeze its way out of the pelvis. So first, baby descends, so it comes down into that pelvis. The progression of head into the pelvis, the fetal head enters the pelvic outlet. The degree of the descent is marked by the stations. Remember, it'd be like a -4 when it first starts getting in there, and then can work all the way down to 0, and then to positive, like +4 would be out. And then the occiput, the back of the head, is transverse or sideways in the pelvis because the pelvic inlet is widest from side to side. So it comes down and is kind of transverse in there. Next, so kind of move ahead. So baby has come down and its head is turned sideways. So now babe went from facing mom's spine to facing mom's side. Okay. Now next is a flexion, which the fetal head meets resistance from the soft tissues of the pelvis and the muscles of the pelvic floor and cervix, and then the chin flexes against the fetal chest. So now it tucks its head down in, and that's how we get the back of the head presenting. Then we have the internal rotation, which the fetal head rotates to fit the pelvic cavity, which is widest in the anterior posterior diameter, usually left to right. And then we have our extension, which begins after the head starts crowning, and the head passes under the symphysis pubis, the occiput and anterior fontanelle, brow, face, and chin pass over the sacrum, and coccyx over the perineum. Then we have restitution, where the head turns to realign with the body, and a lot of time doc may be helping the baby turn its head after its head's been born. You'll have kind of that short waiting period where you're like, okay, we're waiting for the next push. The doc's helping babe reposition. And then we have external rotation of the shoulders to the anterior posterior positions in the pelvis. And then we have the expulsion, which is the delivery of the rest of the body with the anterior shoulder before the posterior shoulder. So in this diagram, again, baby comes in, it is descending, you get the flexion, and get the internal rotation. So it comes in and then it turns with its face kind of smushed down into mom's spine. And then you get some extension. So right here would be head is crowning, and then you get the extension. And then the restitution, where baby's head turns again, right? And or the restitution, where the body's gotta turn, the external rotation, and then the expulsion, where babe comes the rest of the way out. So it's gotta turn its head a certain way to make its way out. Who knew there was so much that was involved with a baby being born? All right. Placental separation. So after the baby's born, about 5 minutes usually, the uterus contracts firmly, decreasing its capacity and surface area of the placental attachment. So it squeezes down and cuts off the blood supply. Then it begins to separate, resulting in bleeding and formation of a hematoma between the placental tissue and the remaining decidua. The hematoma speeds up the separation process. Uterus is usually globular in shape, and the fundus usually rises a little bit above the abdomen, where it suddenly gives a gush or trickle of blood, and the umbilical cord actually lengthens. So you'll see it actually come out of the vagina a little bit. And then at that point, we have mom bear down to help deliver the placenta. And then the shiny side of that placenta is the fetal side, and it's called the shiny Schultz. And then that meaty side that was against the mom's body is called the dirty Duncan. So that's when you would look at that placenta and make sure that all the pieces are intact, because if there's a chunk missing from mom's side, that could still be in mom's uterus. then mom can continue to bleed and she's not going to contract and clamp down and cut off that blood supply um, with the contraction. She'll stay what's called boggy, and we'll go through more of that in detail. All right, and then we have factor number 5, the psyche, which is affected by, a person's culture can affect that. Sometimes people need to be completely um, quiet because of their culture. You're not able to make a peep, things like that. Pain tolerance. Maybe mom doesn't withstand pain very well, so then she kind of panics because she's lost control of her feelings, and the pain is unbearable for her. Fatigue can play an effect when someone's tired. They may get more crabby. They may not have as much resilience. Education, if they know what's coming, that's usually helpful. They can usually withstand a little more, especially if they know what's coming. If they've had a previous experience, maybe they had a terrible experience, so now they kind of panic when it gets to a certain stage. They may have anxiety that can affect it. They may have personal coping techniques that they use to help them through, like listening to music or concentrating on one thing or closing their eyes or breathing. A good support system can help them through the birthing process. And then again, that preparation, which kind of goes into the education of what's to come next. Then we have maternal systemic response to labor. So, what is mom's body doing in response to the labor process? So, the cardiovascular system. So, essentially, what happens is we have an up to a 15% increase in cardiac output with each contraction that mom has. So, positioning in labor is extremely important. A lot of times, we want them in the supine position, but we want to have the head of the bed elevated so that way mom's not laying on her back and baby and uterus and all that extra weight isn't pushing on her superior vena cava. So you want the head of the bed elevated a little bit. And then if they can't be elevated a little bit, then we may want them on their left side. We also have a cardiac output that decreases and the heart rate increases and the stroke volume decreases when they're laying on that supine position. And then again, that side lying position is the best position for a laboring mom, because we get all that pressure off the vena cava, which helps increase that cardiac output, decrease that heart rate, and increase that stroke volume. Other things that happen is the blood pressure will actually increase during contractions, which makes sense. There's a lot of pain going on, so we're going to see that increase in blood pressure. Respiratory system, we have a higher demand for oxygen because mom's using up more energy and is breathing more, and baby may be needing a little bit more as well. Then renal system, we have when basically the infant's engaged, the bladder is being pushed forward and up and out of the way to make room for that baby. So we may actually have edema that occurs, and so it may be hard for mom to urinate, or we may have to put a catheter in, or you may see even a little bit of blood in mom's urine from that trauma. Gastrointestinal, we have a delayed gastric emptying, frequently a lot of nausea and vomiting because, again, the sympathetic system's kicking in, and so things aren't emptying. We have stuff being shoved out of the way as baby's trying to make its way down through the pelvis, and so stuff just gets squished and moved. And then our immune system. So white blood cells increase to 25,000 to 30,000. We have that increase in white blood cells due to the body's normal response to stress. So it thinks that there's something major going on, so it sends out all those white blood cells to help fight off things, help the body to get back to normal homeostasis. All right, and then the last slide here is maternal systemic response to pain or to labor. So when you look at these pictures, we have the first stage of labor, which is at 0 to 3 centimeters. We have the second stage of labor, or the first stage, the second stage, the late stage, and then the delivery. Um, so this is as mom dilates 0 to 3, 4 to, what was it? 4 to 8 centimeters, 7 centimeters, and then the 8 to 10, and then the actual delivery, the pushing is where all the pain is located at here. Now, The darkest colored areas indicate the location of the most intense pain. Then the moderate color indicates moderate pain, and then the lighter color indicates mild pain. So depending on the intensity of the contractions, the more the intense the pain is. And as the baby engages and descends down into the pelvis, the pain actually moves from contraction pain, so that's squeezing around the stomach, to the perineal pain as baby's actually being delivered. And you can actually see it here as it works through. It shifts from the pain here in the abdomen from contractions a little bit down here as baby's down in the pelvis, to shifting down even farther from the abdomen into the lower part of the stomach and the back, and then finally most of it's just in the peri area and not as much in the abdomen as the delivery occurs. So again, that's the end of this PowerPoint slide. A lot of this we'll review in class. We'll go through how to read contraction strips, things like that in class. So make sure that you watch this video so that way it'll be a good refresher for you.